And Kathy Roy Horn from the Hunterdon Medical Center.
Marita Nash from the Hunterdon Medical Center, which is in Flemington, New Jersey.
So how did you two come to work together? Where did it start?
Well, I've worked at Hunterdon Medical Center for about 32 years.
And I joined her 17 years ago.
Right. And it's worked well ever since then, I'd say, in terms of our interests and our passion and our real intent to do good work there.
Commitment.
Did you have that kind of relationship with EVS before Marita showed up?
Well, actually, I've found that EVS directors in general are very well intentioned and are always trying to do good work. Marita, I think, brought some special skills to us about how to collaborate and how to communicate, and was, I think, even more committed than others, perhaps, to get that good job done, despite all the barriers that occur at times.
So what were some of the things that she brought that was special?
Well, Marita was willing to work with me on whatever things we saw in the literature that were new, that we should explore. If we see a new product coming out or a new technology, we generally email each other and say, "Did you see this? What do you think of it? Have you seen this at your conferences yet?" Yeah. And if it's something we both think may be worthwhile, we contact, and Marita tends to do this, contact the vendor and may bring it in for a trial. And so we do a lot of that kind of thing. When we have problems, I always let her know where our problem areas are. If we have a cluster in our ICU or anything like that, Marita gets a phone call and we talk about what the clinical issues may be, but is there a potential also for there to be environmental services issues going on? And then she gets to work with her staff on that, and I get to work with the clinical staff, and we really have been very successful in bringing numbers down and stopping clusters readily when they happen.
Agreed.
And were you in EVS before you came to?
Yes, I've been 35 years in the field. I've worked in hospitals from as small as Hunterdon, which is 178 beds, to as large as 550 beds. The culture of Hunterdon is extremely helpful to all the employees who work there. There is a team commitment to patient safety and patient care.
And what's it been like working with Kathy?
It's been finding a gem. She is collaborative, which is awesome. She helps identify needs. We communicate to each other what our needs are, and then together we build and make a plan, and we enact that plan, and often to the better of patient safety and patient outcomes.
How did you recognize this gem?
I'm not sure how I could say that, how I recognized it. She is, she's just a unique person in a lot of ways. We have direct collaboration, and we have indirect collaboration on a lot of peripheral activities in the organization. And Kathy's passionate, very hardworking, committed, and extremely helpful, sometimes in just the basic common sense. And I've told her this before, so.
Tell me about some of the things you worked on together.
Well, we've worked on outbreaks when we've had them. We had a norovirus outbreak not that long ago, last spring.
Right, the spring of 2010.
Yeah.
What happened?
Well, for one thing, it was the first time we'd had a norovirus outbreak at our facility. And there were a lot of people getting sick very quickly among our staff members and a couple of our patients. And so we talked together, when I found out about it, and talked about what the cleaning procedures were on that unit, what they needed to be, how we needed to be checking on things, how we need to make all the staff aware, clinical people on that floor, ES people on that floor. We had joint meetings with the clinical staff and the ES people. We need to make sure everybody was staying home if they were sick for a couple of days after they were well again. So there was a lot of quick action that developed around that project. And I think that the outbreak came to an end in about 2 weeks, but we had quite a few people sick in the interim because that's a really quickly moving virus. And until people start to take it seriously, we were seeing cases.
And wasn't it initially identified with the help of a physician?
Mm-hmm. Yeah.
So the entire team, from the medical staff to the clinical caregivers, PCAs, RNs, and including the environmental services staff, were part of the solution. So it was wonderful.
And what does that mean? Tell me more about that, the entire team. How were they part of the solution?
The entire team took it seriously, with intensity, with a desire to correct and make sure that all equipment was cleaned, surfaces were cleaned, communication was thorough and efficient to the extent that it was possible.
It was at a time when we were also seeing some elevated numbers of VRE on that unit. And we'd had a
That's
little
right.
trouble getting them to pay attention to that because that didn't affect them personally, and it was just life goes on in healthcare as usual kind of thing. But the norovirus outbreak really got their attention because healthcare workers themselves were sick, and they could see the transmission between themselves and to patients. And so they really then, became aware of what was going on, became very careful about what they were doing. I had no question that our EVS people would start, cleaning the way we needed them to, and we did step up the cleaning procedures at that time. But the clinical staff, we'd been struggling to get to clean the things that they use, and so they really stepped up to the plate at that point and started doing that much better than they had been actually.
On that particular unit.
Right.
I think we had better compliance in the rest of the house with cleaning of equipment and because we've been dealing with that for several years now.
Right.
So you convened people when it became clear that there was an outbreak, and take me into one of those meetings. What was that like?
Well, we had it right in the staff lounge
Right.
On the unit, and invited nursing staff as well as the environmental service staff on duty that day, and began to discuss
Right.
the issues and the solutions.
Yeah. We started out with an educational component to it. Talked to them about norovirus and its incubation time and how rapidly it would spread and what people's individual responsibility needed to be. And then talked about what the plan was and who needed to be doing what differently. And asked people if they had questions because they were concerned about getting sick themselves, bringing it home to their families. So it started out as kind of a lecture education piece and then went into a lot of discussion about people's concerns and what we needed from them.
And the practical solutions to make that happen.
How long did it take you before you realized you were winning or that you were going to get ahead of this virus?
Well, of course, we had our line list going, our epi curve, and we were just watching each day for any new cases that we saw. And I think after the first week, we started seeing fewer cases each day.
And I would say around the 10th day, not that you ever have a comfort level when something like this is going on, but by the 10th day, we felt more comfortable than we had in the first
Right.
6 or 7.
And then after 2 weeks, it really...
Yes,
Yeah, that was the end of it. We haven't had a problem with it since.
right.
Is there a sense of accomplishment from the folks who are...
Absolutely. Yeah, absolutely. I mean, you never want to have that kind of thing occur in your facility. It's kind of like when the Joint Commission says, what keeps you up at night? A norovirus outbreak in my facility is what would keep me up at night. So,
And that was a unit that we'd really struggled to have better practice in terms of cleaning their own pieces of equipment and, paying attention to hand hygiene. And so, to me, it seemed as if the norovirus outbreak was a little bit of the silver lining of it was that it improved practice
absolutely.
over time.
Absolutely.
And their VRE numbers went down, and they've stayed down, and that's been about a year and a half ago.
Absolutely.
So that, in a way, that worked to the good.
Tell me about, do you have some awards programs in your hospital?
We do. We have several, actually. We have an overall organizational award that we call Caught in the Act, which is generally run through Human Resources, and any employee can acknowledge another employee for going out of the realm of their job, quote unquote. The other awards that we have in our own department, Kathy has in infection prevention, she has an Attention to Prevention Award, which the Environmental Services Department as a whole was the first entire group to receive the award. We weren't the first to receive the award, we were the first group to receive the award. And since then, we've had individuals receive the award on an individual level.
If I could just comment on that, that was because originally it was intended to be for an individual. But, our environmental services staff functioned so well all the time that we really had trouble trying to pick any single individual out of it and felt that we would be remiss to try and do that. And since that was the case, we thought it was appropriate. We had to have some discussion to get to that because it wasn't designed to be a group award.
Right.
But then we thought, that's the only right way to do it.
How many people are in the EVS department?
We have approximately 70 people. We function at about 52 full-time equivalents, but we have part-timers and per diem. And in addition to those awards we've just mentioned, in our department we also celebrate Environmental Services Week. We also have a Shining Star Award, and we give that generally in the month of June to employees who have very few deficiencies in their quality control inspections. And last year we had several employees who had less than 10 deficiencies for the entire year of previous quality control inspections, and we average at least one quality control inspection per employee per week. I have had several employees who have had no deficiencies, and that's really what generated the Shining Star Award to begin with. How do I recognize these employees who do such stellar performance all year long? And that's really gone over well.
Anything you want us to add to that?
No, I think it's a wonderful thing.
You were there when
That's
we
right.
did
I
the Shining
go
Star
to those
Awards. Yep.
award presentations and
And during ES Week, you send a nice thank you note,
right.
which we generally share, and the staff appreciates that. And also the infection disease physician, Dr. Gugliotta,
Right.
stops the staff on the units as he sees them cleaning. And when he sees something that they're doing that's very thorough and appropriate, he reinforces that, which is, they love hearing from all of you. So
That makes a big difference.
it does.
Yeah.
It does. Yep.
So there's a sense of it sounds like a camaraderie, of caring, of collegiality.
Yes, absolutely.
Yeah.
Yep.
There was something you mentioned on the phone. Was it the sometimes, always? What was-
right.
Say it to me. Tell me what it is.
The sometimes, most of the time, and always concept came to us because we were focused so much on hand hygiene. And there we talked about having a red rule for hand hygiene, that there was never a time when you should forget to do that, that you really had to do it all the time. And so when we talked about how our environmental services cleaning should be, we thought that that same concept applied. That if people needed to have clean hands to touch a patient, that there needed to be a clean environment that they were going to touch a patient. And so we consider our environmental stewardship, our environmental services people to be our safety stewards. And we say to them, you have a very important role in patient safety. And talk to them about that the clean environment is very much like the concept of having clean hands. And what good are clean hands if the environment is not clean?
Right. And we reinforce with the employees that we do want them to prepare the space as if their own mother was going into the room, and to bring it to their own level each and every day and each and every time. This is important to the next patient. It's important to you. And we express our gratitude for their contribution each and every day.
So explain that principle. Go ahead and walk us through all three of the choices there. The sometimes.
The sometimes, the most of the time, and the always.
Right. Well, basically we're talking about people who think that if they remember to do it sometimes, that's pretty good, and that's good enough. And there are people that we can often get to the next level, and they think that's okay. And what we're trying to get them to realize is that unless they do it always, or at least their goal is to do it always, that they've put patients at risk perhaps. And while we recognize that people will make mistakes and they will get very busy and they can walk into a room kind of unconsciously and not do a good job, if they have made a conscious choice that I'm going to cut corners today, I'm not going to do such a good job, I'm not going to follow the sequence for cleaning that we've outlined, then they need to recognize that there is risk to our patients in making that choice. And so we really expect them to strive always to do it the best way possible.
So one of the things that I've heard in my conversations is that there's, because there's so much at stake, people get very focused on protocols and measurements, and in fact, that's how they relate to the environmental staff. It's through the checklist,
Right.
which creates this kind of sense of being, micromanaged and fear, but yet the stakes don't go away. The stakes are still there, right?
Right.
Right.
But that's not how you're doing it. And I know the protocols are important to you, but there's something else going on. Tell me about that. What is it that you're trying to cultivate?
Well, we've thought it very important to work on the relationships between people, because I think in healthcare, we've found that it's not all about education. You can walk up to any healthcare worker, an EVS worker, or a doctor or a nurse, and ask them if they know the correct information, and usually you'll find that they do. But if they don't do it, and if they don't care enough about each other to do it, then despite the best education and all the knowledge in the world, they're not going to do a good job. And so we've really tried to get people to get to know each other. We try to make sure people are assigned from
Consistently.
ES to the same areas, so
Yeah.
people do develop those relationships. And professional staff, unfortunately, do have a tendency to look at the EVS worker as less knowledgeable, almost as a second-class citizen, if we don't get on them for that kind of thing. And until they get to know people, that tends to be the way it works, especially if you're suggesting to the clinical staff that it's their fault, so to speak, that there's been transmission of organisms. And in infection prevention, we're in the habit of giving feedback to the staff about the number of organisms that they've had in their unit. We can even track for them where transmission occurred. And if we can show that a bug like VRE, for instance, or MRSA, has moved from one room to the next, then it's clear that that's been through clinical staff. So when we work with environmental services and make sure that they're at the medical team training and considered
Six
as part
Sigma,
of the
right.
healthcare team, that really makes a difference. The EVS worker, especially if they're new to healthcare or new to Hunterdon perhaps, may not be comfortable walking up to the bedside with the patient there and doing the things that they need to do. And so it's a change in how we view them and how they view themselves
Yes.
that help them to do the job that they need to in interacting with the clinical staff, interacting with the patients, and getting close enough to do the job
Right,
that's
the comfort
best
level
job.
that's necessary to
Yeah.
perform the tasks. Yep.
So if you were to extrapolate from that and look at the year ahead and what this event today is designed to kick off, what kind of products and services do you think would be ideal to really have impact, to make a difference?
Well, I think it's helpful for people to know about the concept of medical team training, at least. Whether they go into that with a contract with somebody to provide that kind of service, or if they just read up on it and try to put that kind of practice into effect at their facility. But the whole idea behind medical team training is that systems may fail not because of a problem with the engineering of the system, but because of a lack between relationships with people.
The human factor.
Right. And so if you try to improve the system alone and don't work on those human factors, that you won't have as good an outcome. So I think that would be a very important thing, because we do tend in healthcare to focus on the knowledge and blaming people for things, perhaps. Sometimes I think about the way we deal with problems, and it's the old ABCs: assess, blame, and criticize. So that's not a good model that works. But certainly, working on the culture and getting people to understand where their attitudes interfere with their best work, I think is a good thing.
I think one of the other things that would be critical too is that cleaning is everyone's responsibility. It's not relegated to one department or one person on a floor. That when we made that culture change several years ago now, everyone owned it, everyone participates in it, including the physicians as they clean their stethoscopes before they see the next patient. So if that's a culture change for your organization, then I would say begin it soon, because it's necessary.
Right. We found we had gaps in what was being cleaned. It was clear who cleaned the environment, and it was not clear who cleaned a lot of medical equipment, whether that was a stethoscope or a blood pressure
Pulse
cuff
ox,
or pulse ox, right? And so, it's not productive to only work on the things that environmental services clean and
Right.
leave all those other things dirty. So that's been a struggle. And actually, it was a struggle several years ago, even to get administrators to really understand the linkage between infection prevention and a clean environment. That was not at all clear-cut to administrators.
And I think that's where you and I excelled, in that we went to, our administrative team has a format or a program time, they call it the ops meeting. And we went together to present our case on how we felt we could impact after the 2003 HICPAC guidelines came out. And that was, we did a personal appeal. We presented data and evidence and the direct patient safety impact. So that's what made us successful, I think.
I think people do need to feel as if they can go to administration
Absolutely.
and tell them what they need. Because what may be very clear to us, like the relationship between infection prevention and a clean environment, is not necessarily clear to administrators. And until a few years ago, I don't even think administrators focused much on what the costs of infections were. You know, both ES
Absolutely.
and IP are non-revenue producing departments. And so we were not well budgeted, resourced. And one of the main messages we had to say to them, and people don't necessarily like to hear this kind of thing, but it is that we were under-resourced historically, and that today that just doesn't cut it, that there's so much benefit to be had from resourcing
Absolutely.
both departments effectively in terms of
Absolutely.
reducing infections, that revenue that has to be put into our departments pays back in multitudes.
From a cost avoidance.
Right.
Absolutely. And the process of identifying the cost avoidance together, I think, made us a powerful statement to our administrative team. They listened and they responded very well.
Yeah.
So you were partners in packaging a message around cost avoidance.
Yes.
Tell me a little bit more about that partnering and about how the administration noticed you and listened to what you had to say.
Well, the impetus for it this was when the CDC focused on the touchable surfaces. And we realized that with current EVS staffing, we couldn't add that to the workload for that department. And so...
And expect it to be accomplished.
Right. And so at that point, we decided we needed to make a business case for this. We needed to come up with some idea of what isolations were costing us,
Yes.
Whether patients got infected or not. If we were going to isolate them, it was going to cost us money for the private rooms. And so we tried to put a cost on that, and then we tried to put a cost on what we were asking for in terms of EVS additional staff.
And when we did the analysis, I presented it to my administrator, and then we took that information to ops and presented it to the entire team.
You did a time work study on that,
Yep,
right?
absolutely, yeah.
Trying to see what it
Yep,
would cost.
And we did the time work study on what it would cost us to actually spend the time at the bedside cleaning patient touchable surfaces. And we did that analysis compared to the cost of an HAI or colonization. And we took those numbers, and it was clear that the cost avoidance was worth the investment, and our administrative team supported that. We want to thank them for that.
Right.
I want to come back to something you were talking about earlier when you talked about the importance of the rapport and the attitudes in getting impact and getting results, and how it was not necessarily just education or knowledge. And I was asking the question about what might come out of this, what might we see in the year ahead as products and services as a result of this AHE-APIC collaboration and the task force. What could be, again, what could be done that would allow people to see, for example, the benefits of those attitudes and do assessments? I just know from other areas, gender equality, civil rights, even student-teacher relationships, that sometimes when you'll ask someone, is there a problem, they'll say, oh, there's no problem here.
Right.
And yet, so there needs to be a way to make it visible and then to give them something to do about it.
Mm-hmm.
Any thoughts on that?
Well, I don't think there's a problem making an issue visible in this field, because certainly we see infections and we see transmission of microorganisms, whether infection is present at that time or not. So I think today there's good recognition of the problems that are inherent and of the money that's going to be lost if things are not fixed.
And will be tied into formulary remuneration in the future under CMS guidelines to
Right.
begin with.
Right.
So there's a financial incentive now for hospitals to do their best to get it right from the beginning.
Right. And I think we're at a time when people are searching for new ways to do things, because the old ways have worked to a point, but have not worked well enough for hospitals.
They're not
or
getting us to zero
healthcare,
tolerance,
right?
right.
To get the numbers down to what they need to be and to make our patients safer. So I think it's time now, having gone through this, all the data piece of things, and the technology can only take us so far,
Right.
but it's clear that the human factors need to be addressed. And there's a science out there on that. So I think we need to use it. You know, we need to talk about how relationships develop, and the time investment that's important to do that. And we need to have people who previously had silos with departments totally separate, meeting together, talking together, recognizing each other's worth. You know, it's difficult for people to understand that although they have very good intentions and they may be expert in what they do, that they can be contributing to the lack of safety in healthcare. And so if people understand what clinicians do and what environmental service people do, I think it's helpful to get that whole picture. And for instance, with
And breaking down the barriers that prevent the activity that's necessary to happen.
right.
Whether it's giving the environmental service employee enough time to do the job correctly, because you may have a patient waiting for that room. The environmental service employee at our facility is encouraged to speak up. If you don't have enough time to do the room correctly, call your supervisor. We'll send you more help if we can, or we'll interact with the nursing supervisor and let her know why the room is being delayed. We'll go talk to the patient who's waiting for that room. We'll let them know that their safety is paramount to us, and that's why we're experiencing this delay right now. Most often, we get another person in the room to get it cleaned so that the patient doesn't see a wait.
It was not unusual in the past when there was a problem on a unit for our nursing staff particularly to say, I think the unit's dirty. And instead of looking at themselves, which is a difficult thing to do, they would look for somebody to blame. And you know, today we have technology that shows that we have a clean environment. We started using one of the solutions on the market to document that a clean surface is indeed clean. And so our clinicians can no longer say, oh, the transmission's because we have a dirty environment.
I was asking about the attitudes, and take me into the medical team training and help me see what happens there that is working so well for you.
Well, we can start with the fact that the environmental service personnel are included in the team training, which is huge for some facilities. And the team training is designed to assist in the breakdown of the silos that Kathy was talking about earlier. It's several sessions, and what do you recall about those sessions? They're built around...
Well, it's quite an investment in time, because there are quite a few educational sessions, and staff do role playing, role modeling, and they have conversations in a setting where physicians are there, nurses are there, EVS people are there, social workers. The people who would work on that unit get together for these learning sessions and then for these role modeling sessions. And the whole idea is to be comfortable enough with each other that you are comfortable saying to somebody, you forgot to do this, or that's not what the protocol is. And it takes practice talking to each other and get to know each other to do that. And if there is an outcome that's less than ideal, they have a process where they meet and have what they call a debriefing to talk about what happened to that. It's not dissimilar to the root cause analysis that you hear so much about in healthcare today, where the team involved, right? The team involved get together and talk about what was done well, what was not done, and things come out that you don't expect. You find things that you go, wow, I wouldn't have thought that's how it happened. And it really is worth the time investment that it takes. You know, it's difficult in healthcare to set aside time for meetings. It's difficult to get these things on people's schedule. But once you've done a couple of these debriefings or failure modes or root cause analyses, you find that the information you get from the people on the ground, so to speak, the workers doing the jobs, is so valuable that it really is worth the time that it takes to do those things.
Can you give me an example of something that came up that was a surprise?
Well, I can think of one that isn't really about EVS and infection prevention, but it was, I think, a perfect example of the kind of things you find out. We were doing a root cause analysis on a urinary tract infection that a patient had had, and we got the players together who had been taking care of that patient. And after sitting around for probably 20 minutes going through a formal process that we have. We ask all these questions, many of which we know the answers to before we start, but you go through the process. And so we were going through them, and we really hadn't found anything, and it was almost time for it to end. And then someone remembered that the patient had been going over to radiation oncology on a daily basis for their radiation therapy. And someone said, well, do you think that the patient has had the Foley bag put up on their abdomen when they moved over to the linear accelerator for their therapy? Because anybody in the hospital would say, oh, we don't do that. We keep it down below the level of the bladder. So one of the follow-up actions was to call over there and say, how do you handle a Foley catheter when a person comes over and needs their radiation therapy? And they said, well, we pull them across and we put the Foley on their belly, and that was it. And while we will never know for sure that that's why that individual got a urinary tract infection, that was a gap in our system, and they were seeing that patient daily for weeks and doing that. And the problem was that they didn't know that that was not the way to do
Best
it.
practice.
And there was a better way to do it, which they quickly and immediately implemented. But that was something we wouldn't have figured out if that person hadn't been at that table and said, oh, they were going to radiation therapy every day.
So what do you do to break down the silos in the medical team training? You mentioned that.
It's a process of communication through role playing.
You really need a good group facilitator.
Yeah.
You need somebody who knows how to do that kind of thing. So whether you have somebody internally who's expert at that, and sometimes you do, there may be a person in QI or somebody who just happens to have those skills, or of course there are companies out there who will come in and do that kind of thing.
And they get the EVS staff involved so that
Yes.
the relationships are getting built back and forth.
Right. The idea is to get everybody involved. They do it unit by unit. So for instance, you would take your maternity staff or your ED staff, and they would all come to these sessions, and there'd be multiple sessions. They don't, of course, necessarily all get to all of them, but the idea is to get most of them to most of them. And enough of the exercises that are done are similar, that people get a feel for it, and just having them sitting around the table for a couple hours together and eating together and that kind of thing.
Right.
People start talking about themselves, their families, their work life, and it helps them.
Yeah, the session lengths were either 4 hours or 8 hours, depending on how the unit wanted to staff it. So it was very helpful in that regard.
So we're getting close to the end of our time. Is there anything else, any anecdotes or experiences that you've had that you feel like would be helpful?
Several years ago, we started to see an increased rate of C. difficile infections in our facility. And it was very troubling because people were very sick with it. And we had not heard anything about a strain change at that time. So we called the State Department of Health, and they called the CDC, and found that indeed they had 2 teams out investigating outbreaks of C. difficile. One, I believe, was in Maine, and the other one in Georgia. So they didn't have a team that they could send to the Huntington Medical Center. But
And to Kathy's credit, she was one of the first to identify that that we were experiencing it.
right, it was very scary actually at the time, because it was a big change in how our patients were getting ill with C. difficile. And so we met quickly, of course, and I mean, Marita had known that we were seeing an increase in cases well before we called the state.
Absolutely.
Because every time we were seeing that bug, we were getting cleaning done in a different manner since our numbers had been going up. And so we did put different practices in place. We changed cleaning products, and we started doing double cleaning on those surfaces to make sure that they actually were done, because that was before we had this touchable cleaning thing going on as firmly as we have it in place now. And we really brought that outbreak under control pretty quickly, and our numbers have been going down ever since. And it was just about a year or so later that Cliff McDonald from the CDC identified that this was actually a new strain, a more virulent strain of C. difficile, and many, many facilities started to have problems with it. after we did. We were on the cutting edge of that one, which was not really a good thing, except that it did allow us to get it quickly under control. And that was largely, I believe initially at least, as a result of cleaning, because that's a bad bug in the environment.
Once it gets in the environment, it's difficult to eradicate it.
So we probably had a fairly heavy bioburden of that bug in our healthcare environment, in our patient rooms, and with Marita's staff doing all the interventions that they did at that time, it really was beneficial to our patients. And to their credit, because responding to an outbreak is one thing, but maintaining that response is another thing.
Well, they got it. They got the entire concept of they are the patient safety stewards. They got it. They got it. They work it every day. They live it. They breathe it. They got it.
Tell me more about that. What is it? You say that with like intensity. What does that mean?
Well, it's because they are on the forefront, the front line of patient safety in everything they do, from using the wet floor sign before they start mopping the floor, placing it, making sure it's in the right location, to their patient touchable surfaces, to preparing the space as if their own relative was coming in. My staff gets it. It doesn't mean everyone's perfect. It doesn't mean there isn't a time that I don't have to re-counsel someone. I was just doing that the other day. It goes back to our sometimes, most of the time, always notion. We are human beings, but for the most part, our employees, our culture, they get it. Patient safety is there. They own it, they live it, they breathe it, they do it. It's important to them.
I've had times, I should say, when my fear was that I would tell Marita something that she would then say, we can do that, when it wasn't environmental services' job to do it. That somebody else needed to speak up and say, we need to do this, the clinical staff, for instance. And so, when it comes to adding on jobs, whether it's cleaning the medical keyboards or doing the touchable surfaces, Marita and her staff always have a, yes, we'll do this, rather than a, no, we can't, or we don't have time, or something like that. And that's a very refreshing attitude to have in healthcare.
Well, and if I need resources to get it accomplished, I identify what they are to you and to our administrative team, and we, together, passionately go after it if we have to. So we identify our needs to each other, and we're back to the beginning of what makes us so good. So.